a lot of women are, I'm going to start over. Let's start over. I'm out. I'm out. I'm out.
Hit the turtle on its back.
No, I'm out. I think that sucked. I think I did terrible.
No, you didn't.
You did great. I think that sucked.
You always do great.
No. Let's try it again. Let's try it again. No, it was terrible. No, we're doing it. We're doing it again. We're doing it again.
Welcome to Balls Deep, a humorous yet informative medical show with a mission of optimizing your performance in the bedroom, the bathroom, and the boardroom. I'm your host, Dr. Joe Pizzona, a board-certified urologist and CEO of Pizzona MD. We hope you enjoy. Now, let's jump right in.
Hi, Stream Team. It's me. It's Kat. Still, we are without Dr. Pizzona for our third episode with Dr. Brook Faught, Doctor of Nursing Practice. And Brooke is with me to keep talking about women's sexual health, which yet again, not enough people are talking about. So, without further ado, let's go deep.
Balls deep.
Okay, Stream Team, we are here still with Dr. Brook Faught. And Brooke, today I wanted us to dive a little bit more deeply into talking about male sexual dysfunction versus the attention really, that male sexual dysfunction gets versus the attention or lack thereof that female sexual dysfunction gets.
How much time do we have?
Well, probably not enough, but I would love to hear your thoughts. It's interesting to me, and I'm sure it's interesting to listeners, that it took so long for the medications we talked about on the last podcast to even be approved. Is there a medical reason for that? It seems like Viagra and some of those male drugs were approved very quickly, but yet attention for a drug that might help low libido issues in women, nobody was interested in. How in the world could nobody have been interested in that?
Yeah.
What's the story?
Yeah. In general, historically, most medical studies utilized male subjects, right? And the data was then assumed to be relevant for male and female subjects. And this was up until recently, to be completely honest. And
so they weren't even studying women at all ever for any reason.
For the most part. And we're talking white males, right? You know,
Okay.
and so we really didn't have a diverse population of individuals that were studied. We really pulled from the same, pool of subjects. Well, now there's, for the most part, been an intention to really kind of diversify that the study population so that we can really look at what we're intending to study versus studying what's available or what we think we should study, and then extrapolating that and applying it to what we are actually looking at. That being said, in this case, now that we're starting to specifically study medications for more, what's the word?
For women's issues.
Yeah, for progressive, women's sexual health issues. We never, ever would have looked at or considered bringing a women's sexual health medications to market in the 70s, right? Or the 60s.
I don't think so.
Right?
It certainly didn't happen.
The world would have burned down had we considered something like this. But all of that being said, I think that trying to think which direction I want to go with this. There's a lot of ways that I could go with this. And like I said, we could talk for an hour on this because I have a lot of thoughts and feelings on this.
A lot of feelings.
I have a lot of...
but this drug, like the Addy, I'm sure since this side effect profile was pretty low. You see so many drugs on TV, and at the end, they tell you all the ways that you can die from taking this drug. You didn't really give us that with the Addy. It probably got pushed through fairly quickly.
No, it did not.
Shocking. It didn't.
I would say probably one of the legit reasons is that as women, we are a bit more complicated because of the fact that we do have menstrual cycles. We do go through puberty and we start menstruating, then we have babies. So there's that element of potentially carrying a baby and the risks associated with that. Then we go through menopause. So there's a lot of different elements to us that complicate research that men don't go through, right? So they have to consider that when they're looking at clinical trials. So it's a lot easier to just study men, right? And then they have to take that into consideration during a clinical trial. Is the woman pregnant? Are they on contraception? Are they on hormone replacement? Do they have a uterus? Do they have 1 ovary, 2 ovaries? Like all these little details that they have to look at and take into consideration when they're looking at the data too. So all of that is relevant to considering the studies, considering the data from those studies, considering the publications, and all these little nuances. Once they have the data and they're looking at that data, then they have to make the decision about what the data means and if they want to approve it to actually move it forward. So then the FDA oftentimes will look at it and go, well, we want more research. And unfortunately, research is extremely expensive and extremely time consuming. And what we tend to find is that we'll get these clinical trials from men and they'll go, yep, looks good. And they'll go right through and we'll get this approval for like Viagra. But then for like flibanserin, we might have 10 years of data and then they'll say, well, we want more and more data. And then
are they simply pushing through the Viagra because it is a safer, easier drug to approve, or is it because it is a man's drug?
I would definitely not say safer. I would say...
Okay. So it's not a safer drug. I mean...
I would say there's definitely a huge demand in a lot of these circumstances. So there's,
there's more demand for a men's erectile dysfunction than there is for a women's libido issue drug.
Yes and no. There's more prevalence of HSDD than there is, believe it or not, even, erectile dysfunction. However...
Wait, say that just what you just said one more time.
There's more prevalence of female sexual dysfunction just in general.
That exists more than...
male sexual dysfunction as a whole category.
Well, that's really interesting, and I've never heard that.
Little slap of reality
slap of reality right in the face.
Yeah.
Okay.
But we have Viagra and 17 other, I'm exaggerating.
Many things.
Many PDE5 inhibitors, which are all the Viagra, sildenafil, all the other medications in that category. We have all kinds of testosterone products for men, numerous medications to enhance or improve sexual dysfunction. And we have very, very limited options for women's sexual dysfunction.
Is part of that because women don't want to talk about this? When the male business doesn't work, I mean, they'll spend anything. They'll go anywhere looking for any solution to get that part of their business working. Is it because, but you're saying that the occurrence of a sexual dysfunction is higher in women. Do we just simply never speak about it?
There's a lot of reasons behind it.
Okay.
Women oftentimes won't bring it up because, as I mentioned, I think in the first podcast, women are embarrassed. They're afraid that they will embarrass their healthcare provider too. Healthcare providers don't bring it up because we want to fix things. And if we're not properly trained in something, we're not knowledgeable about what a condition or symptom is or how to treat it or how to throw a pill at it, then we don't want to bring something up.
That it doesn't exist?
Yeah.
Okay.
Because, I don't want to bring something up and then be like, well, that sucks. Sorry.
I don't know what to do for you. Good luck.
Right.
Okay.
And so it's just a missed area of conversation. And so the conversation never happens. And then the patient leaves and they just assume that this must not be important to them. And they go about their lives, right? And then the media squashes conversation about women's sexuality. And then movies show women just rip their clothes off and have orgasms in 10 seconds.
Right.
So there's this perception that's getting shoved down women's throats that this is how you should have sex and this is how it should be. And so it's this like spiraling of development of our perception of what women's sexuality should be. And
none of which is real or even reasonable or accurate in any way.
No.
None of it, basically. I guess I'm really shocked, though, knowing that the two medications we discussed in the last podcast have been out for 10 years. That's not an insignificant amount of time, but yet we see no evidence of that anywhere. I mean, I turn on the television, every other commercial is a pharmaceutical drug commercial, every other commercial. And I've never seen or heard of these drugs.
Yeah.
Is that odd?
And I'm sure you've seen commercials for, I'm honestly not even entirely sure what the legalities are with regard to like Viagra and stuff nowadays. But we've all seen.
But the blue pill is advertised in every possible medium I can think of.
Yeah, right?
Right.
And we've all seen those, right? But you've not seen a slew of different, commercials for women's sexuality. I know that I've been on numerous media outlets, and I can't tell you how many times they're like, "Oh, you can't say that. Oh, you can't. Don't say clitoris. Don't say vulva. Don't say vagina."
They won't let you use even a medical term, a medical
insane.
Anatomical term to discuss it.
And I can't tell you how many times I sit there and I'm like, vulva. I mean, I
just
try
trying to
so
throw it
hard.
out there. It's an anatomical term, but they won't let you say it.
It's insane.
I think that also perpetuates these feelings that women probably have that somehow our bodies are dirty.
Yeah.
That we're not supposed to talk about these things. Experiencing low libido issues is not something we are allowed to talk about, or that we even should talk about, to the point that we shouldn't even ask our doctor questions about that. And I think that's something we probably really need to work on.
Yeah. Like why can I not say vagina on the news?
That's what it is.
But we can say penis?
Well, they seem to say it a lot. They seem to say it a heck of a lot, and no one seems to bat too many eyelashes at it. So yeah, it's a really good question.
Yeah.
But back to, yes, I mean, we could talk about the male
Sorry,
versus.
I took you down a rabbit hole.
No, I like that rabbit hole. I have a couple of other questions about low libido in women. We've talked about, the pills and things, but are there other things like in our lifestyle? Dr. Pizzona and I are always talking about working to create healthy lifestyle. Are there things that we might be doing to bring about low libido in our lives that if we tweaked, if we made some changes, could make a difference in female sexuality, in female libido?
Yeah, that's a really good point. I'm glad you brought that up, because I always forget to mention this just in open conversation. But I tell patients all the time, in general, obviously every individual is different, but in general, in our practice, men come in, you can run them over with a Mack truck, you can, they can be sick with the flu, they can hate their partners, and half the time their libido is still perfectly intact, right?
Right, it's true.
But for my patients, my female patients, the birds are chirping, or they forgot to put mayonnaise on their sandwich, or the dishes aren't completely stacked appropriately, and libido is in the tank, or it's not where it used to be, simply because everything has to align perfectly for us to be reasonably receptive to sexual cues. And so until we're receptive to sexual cues, we're not going to allow our brain to respond to what's happening physiologically. So what I'm trying to say is, men, it's an automatic type of phenomenon. It's kind of like feeling hungry. We don't tell ourselves that we want to be hungry. It just kind of happens. Whereas for us, we have to pay attention to what's happening physiologically, because all this stuff happens to our body before our brain goes, something's happening, and then we allow it to process, and then we go, okay, I like that, and I want it to happen, and I want to continue doing it. But we can also subconsciously and consciously shut it down. And so all this stuff, it's like the NASA space shuttle cockpit versus the light switch of the man.
Stress, just stress, could have a really significant effect on a woman's libido, no matter what her age, pre or postmenopausal. What about something, what about obesity? What about smoking? What about sleep? Lack of sleep? What about, poor diet? What about those things?
All of the above.
All of the above.
Yeah. And especially when you start factoring in multiple lifestyle concerns, drinking a bunch of sodas, poor diet, high stress. The list goes on and on. Anything that we all know the things that are not healthy for us, right? And then when you layer all that stuff together, it 100% can kill libido. And libido oftentimes is one of the first symptoms of declining health. And we say that a lot with men too, like erectile dysfunction can be one of the first signs of cardiovascular decline. And so oftentimes when men mention that to us, we'll say, well, let's first, do a little cardiac workup.
Is that true of women also, that that lack of libido, a loss of libido could have some cardiovascular relation?
More so with arousal.
More so with arousal.
But
Okay.
libido in general, when a woman comes to me and says, my libido is low, I'm, kind of tired and stuff, I say, well, let's look at your thyroid. Let's look at some other, hormone levels in some cases, not always. But just taking into consideration the entirety of their symptom profile and their history, that's where we might look at a bigger picture to see what may be going on.
Okay, so like Dr. Pizzona and I have talked about in the past, like men, erectile dysfunction can certainly come from these other factors, can be significantly influenced. Same for women. If you're experiencing some low libido issues, you might need to take a look with your doctor at some of your lifestyle choices.
100%.
Okay.
Yep.
Okay.
And even if that's not the cause, it's only going to optimize your libido. I can't tell you how many women say, oh, I just started this great workout routine and I feel so much better. And it has kind of ignited my sexual energy a little bit, even before I've started my Addy or whatever it is that we're doing.
Anything you would suggest, Brooke, other than the pill or the injection, lifestyle changes? Is there anything else that we as women can do to optimize, our interest, our libido?
Playing, just having fun,
Okay. Take the intensity out of it. Maybe.
Yeah. Laughing, I always think that humor is a fun way to just, reconnect and be childlike. And it's easier said than done, right? Life is
Sure.
hard.
Life is hard. Life
It is so
hard.
hard.
And it's hard for women. I think especially women are constantly struggling under a lot of, for lack of a better word, stress in multiple, different categories.
Yeah.
It's hard to laugh and just take a moment to decompress.
Yeah. I mean, try working for your husband. I'm just going to say.
Oh, I did work for my husband for a period of
That's
3
true.
to 4 months, and he fired me, and that is why we are still married. It's the best job. It's the best firing I've ever had. That's tough.
Yeah, right.
I'm not sure I recommend that working with you.
I was going to say, see, if I get fired, that's a different scenario because I don't have a home to go to at that point.
That's right. No. Ha ha.
Oh,
But
goodness.
yeah, no, working for your husband, very stressful.
Yeah.
Can be.
But
Can
it is.
be.
I mean, it's something I have to tell myself on a daily basis too, is, don't take things so seriously because, we can very easily get very wrapped up in things, but it goes with anything is trying not to take things too seriously and take a deep breath. Breathing is so critical. And that's for sexual health, but also just like pelvic health. Cause I do a lot of pelvic health, with my patients that have chronic pelvic pain or prolapse or, even just arousal issues. A lot of it's blood flow concerns. And so one thing I take away from my pelvic floor PT colleagues is deep breathing. A lot of times we don't breathe properly. So just taking, even if it's 5 or 10 seconds to just realize, I bet you don't realize, not just you.
How
but-
often we hold our breath?
Oh my gosh, I do it. I do it as well. Probably just
I think
sitting
I've
here
just
right
done
now.
it. I think I'm just doing it sitting right
We're
here.
both just going,
We're
right?
not breathing.
Our belly should move when we breathe. We're also so inclined to like suck everything in.
Right.
And so we're doing
Especially
this.
as women.
Right?
Suck it in.
We're so inclined to shallow breathe, but really we should be breathing into our bellies. And it's very, very important to fully oxygenate, all the cells in our body. And so learning to do that proper breathing, there's all kinds of, Instagram accounts and podcasts and YouTube channels and stuff where these really well-trained, pelvic floor PTs and therapists can train you on that. I think that's a really good takeaway too.
Okay. Wouldn't have thought of that at all. That's a really good idea. I have one last question, a little bit off the mark. So, have heard this, and I want to get a doctor's definitive answer on this. Can women take Viagra?
Oh, absolutely. I actually
They
prescribe
can?
Viagra.
I thought this was some crazy myth and crazy people on social media. Like what?
Well, I'm a crazy person on social media,
you
but
absolutely are a crazy person, but truly women can take Viagra.
yes.
What happens?
Viagra was initially studied in women specifically for libido, which was laughable because it's not intended for libido in men. It's intended for erectile dysfunction, which is a functional blood flow issue, right? And libido is a chemical imbalance in the brain, or that's how we understand the majority of treatment, right? Well, Viagra doesn't work on the brain. When we look at how it best works, again, it works in the nitric oxide pathway, which enhances or dilates blood vessels that lead into the pelvic floor, so it can help with vasodilation of the clitoris, just like it does of the penis. So just like men, we have that structure. It just is more internal than compared to men where it's more external. So instead of getting an external erection, we can get more engorgement of the clitoris, somewhat external, just that little tiny tip that's on the outside, but a lot of internal engorgement. So if a patient comes to me and says, hey, my desire or my libido is intact, but I don't feel that arousal, that pulsing, that throbbing, my orgasm is delayed or muted or takes too long, or it just doesn't happen like it used to. In that case, that's where Viagra or sildenafil is the generic name of that can be quite helpful. There's other medications, Levitra, Cialis. Those are all what we call PDE5 inhibitors. Those are also acceptable options as well.
And those can all be taken by women? And can they be prescribed to women, or are you
Yes.
in your husband's drawer stealing stuff from his medicine cabinet?
Never want to take somebody else's
That's
medication
a
because
really good point. Yeah. please reiterate that. Do not take
Caveat.
someone else's medicine.
Exactly. Yeah, there's risks just like with men. And so you want to make sure that it is prescribed. You know, if you have a trained healthcare provider, a licensed healthcare provider that knows the pros and the cons, the risks, the benefits, and a pharmacist, obviously, that knows the same, that can run your medication list and your health history and can verify just like a male patient. We use medications off-label all day, every day. And I'm sure plenty of medications that you've used before are technically off-label. But yeah, I mean, it's absolutely, we can prescribe it for you. The only issue is oftentimes it's not covered by insurance if it's like a brand name, but a lot of these medications are now generic.
So, wow. Okay. Mind blown. I thought the answer to that question was going to be, no, you're crazy. I can't believe you asked something so stupid.
I didn't say you weren't crazy.
Okay, but she could have said that I asked something so stupid, but you can take this and you can get a healthcare provider to, I mean, are the side effects sort of the same for men and for women? Are the side effects different for women taking a Viagra?
The biggest side effects are generally kind of like a low pelvic ache, backache due to that excessive blood flow, sometimes headache too. So pretty similar for the most part. Women don't tend to get the vision changes that men tend to get, but it can happen.
Okay, wow. Did anyone else know this? I didn't know this. Okay, I think we need to wrap up, but this has been a lot of what I think has been amazing information talking about women's sexual dysfunction and a lot of information that I didn't know. I hope we've shared some things with you guys that you didn't know and expanded all of our horizons. So let's bring it in one more time for my favorite segment. Just the tip. Okay, Brooke, I want you to help me wrap up. In our 3-part series on women's sexual dysfunction, what are our biggest takeaways? The first thing I'm thinking of is that, hey, guess what? Women have sexual dysfunction issues too. This is not simply a man's issue. And number 2, hey, who knew there are medications? Men have Viagra, which apparently we can also use, and I did not know this. But there are two medications for women, completely for women's sexual dysfunction. Ask your doctor about these. Seriously.
Addie and Vyleesi.
Addie and Vyleesi. Let's say those names again. And third, Brooke, what else should we know about female sexual dysfunction?
Yeah. Low libido is the most common or most prevalent symptom compared to the other symptoms of arousal, orgasm, even sexual pain. However, there's a lot of overlap. A lot of women do have multitude of symptoms all at the same time, so you don't have to have them independent of each other. You don't have to suffer. You can have these conversations, and if you ask a question to a healthcare provider and you're not happy with the answer that you get or the reception to that question, keep moving on and keep asking.
Move on.
Go to ISWISH, which is International Society for the Study of Women's Sexual Health, or the Menopause Society, or the National Vulvodynia Association, or the International Society for the Study of Vulvovaginal Disease, depending upon what your symptoms are.
Wow. I mean, they've never even heard of these organizations, but apparently they're out there. I think we all need to, as women, do a little more digging and be a little bit more honest about what we're experiencing and be comfortable enough asking our healthcare providers to help us.
Yeah.
And if they can't, like Dr. Faught said, move on and find someone who will listen to you and take your concerns very seriously and offer some help.
Yeah. And Kat, we didn't get much into like supplements and over-the-counter stuff. Just be careful. There's not a lot of regulation on that, but maybe we'll do another podcast sometime. But just be careful. Always talk to your healthcare provider. Try not to use things that you don't have guidance on. But
talk to your doctor, I think, is the best. And yes, we will see if Dr. Pizzona will let us come back after these podcasts. It could be that I'm just fired right out, which is possible. But I am very grateful that he has let us take over these 3 episodes. And I'm so grateful to you, Brooke, for helping us shed some light on this subject that I think has been in the dark for much too long.
Yeah, thank you for the invite. It was fun.
It was fun. We're going to go get a drink now. But thank you, Stream Team, for sticking with us. And Dr. Pizzona will be back next time. We'll see if I am. Who knows? Thanks for tuning in. See you soon. Thank you for listening to this week's episode of Balls Deep. If you'd like to join our Stream Team of listeners, please click the subscribe button on your favorite podcast platform. For more information about our practice, Pizzona MD, please visit pizzonamd.com. I mean, did we do okay? Okay.
Nobody's crying. Nobody's bleeding.
Nobody's crying. Nobody's bleeding. This podcast is for informational purposes only, and the content is not intended to be a substitute for professional medical advice. The show does not constitute the practice of medicine. No doctor-patient relationship is formed through this podcast or any of the social media channels related to this show. The use of this information is at the user's own risk. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.